Well, good morning, everyone. My name is David Rowe. I have the privilege of representing the 85th Legislative District in the Pennsylvania House of Representatives. I also have the privilege of serving as the chairman of the Pennsylvania Republican Policy Committee. So thank you all very much for being here. I want to thank our members in attendance, and we're going to just start off with some very quick introductions for members to let us know their names and where they're from. We're going to start with Chairman Struzzi, work our way down.
Good morning, everyone, and thank you for being here. Representative Jim Struzzi, representing the 62nd Legislative District that we are currently in.
Good morning, everyone. Representative Eric Nelson, Westmoreland County.
Good morning, everybody. Representative Brian Smith. I represent the 66th Legislative District, which is Northern Indiana County and all of Jefferson.
Good morning, everyone. I'm Park White Lane State Representative of the 7th Legislative District in Mercer County.
Good morning, Jill Cooper, District 55, Westmoreland County. Happy to be here.
Good morning, Representative Clint Owlett. I have all of Tioga County and the western half of Bradford County.
Good morning to you all. Mike Armanini, 75th District, all of Elk and parts of Clearfield County.
Good morning, everyone. My name is Lee James. I represent the county of Venango and a portion of Crawford County.
Good morning. My name's Representative Leslie Rossi, and I represent District 59 in Westmoreland County.
Good morning. My name's Jamie Barton. I serve in the 124th Legislative District, serving Schuylkill and Berks counties.
Thank you, members. I also want to recognize that online we are joined by Representative Charity Krupa from the 51st Legislative District and Chairman Marty Causa of the 67th Legislative District. We'll also have some members hopping on a little bit later. For the members online, if you do have any questions, please feel free to text either me or Nancy, and we'll be sure to get you in the queue. I also want to recognize Sam Weiland, who is here today from Senator McCormick's office. Thank you very much, and please extend the thanks to our senator for his excellent work in this area as well. So I want to also start things off by just thanking the Byron Stauffer of the Indiana County Office of Planning and Development. We had a fantastic tour yesterday for the members that were able to be here. Rave reviews all around on that front. I want to thank our host, Representative Chairman Jim Struzzi, for bringing the committee to Indiana County, and really for just being a leader on the issues affecting rural communities all across the Commonwealth, even extending beyond the borders of his district. We would be remiss if we didn't kick things off here today with some welcome remarks from President Michael Driscoll from the Indiana University of Pennsylvania. Thank you so much for hosting us. It's wonderful to be here today. The floor is yours.
Thank you, Mr. Chair. Welcome to the Pennsylvania House Policy Committee. It's great to have you here on IUP's campus today, and it's been wonderful to spend the last day with you as you looked around the county and saw some of the great things that happen in Indiana. It's a real pleasure, Chair Rowe, Chair Struzzi, entire committee, to meet with you, see you again, meet you. I want to say thank you on behalf of our county for your service to the Commonwealth and its communities and its people. We appreciate what you do every day to further what we do here in Indiana County. So thank you very much. I also want to thank you on behalf of my colleagues for your support of higher education in Pennsylvania, particularly the state system, Pennsylvania's universities. And you may recall that this system was created by the Commonwealth more than 40 years ago with three objectives that remain just as relevant today. First, to provide high-quality, affordable, career-relevant education to Pennsylvanians. Second, to increase educational access to promote social mobility. And third, to contribute to the state's economic and cultural development by preparing students for success in their career and in their lives. Events like today's hearing are essential to strengthening the partnership between higher education, our communities, and our state leaders as we work together to build a brighter future for our Commonwealth's workforce and economy. So again, we're very thankful that you're here. I hope you'll indulge me as I brag about my university for just a moment now. I do want to call out that Representative Nelson, a member of the panel, is a proud IUP alum who also has been known to teach for us on occasion, bringing his expertise in safety sciences back to our students in that wonderful program. So thank you for that. I also want to mention that this year IUP is celebrating its 150th anniversary. It's a wonderful time to recognize all those who've gone before us since the founding of this place in 1875. And so please join the party, come back. There are other parties that any of you may have participated in the last 24 hours, I assure you. IUP is one of the largest economic engines in Indiana County. We provide jobs, education, research, activities and events, and incredible facilities. And you had a chance to see some of those of you who were with us yesterday, and to see some great IUP basketball in the KCAC just across the street here. We are also a longtime contributor to the well-being of the entire Commonwealth. More than 90,000 IUP alumni are living in Pennsylvania today. We have a brand and a recognition as an affordable, quality institution that is known across the state. This year, 90% of our student body is from Pennsylvania, and that's not unusual with our historical makeup. Through the years, the majority of our students have come from within about an hour of Indiana, but our students come from across the Commonwealth, from every corner of this great state. A lot of our students, many of our students are from rural areas. Many are first-generation college students still today. Many of them are veterans, have served our country in remarkable ways. And we have a growing population of older learners who are coming back to look for next skills, next credential that they need to advance in their careers. Today's college students want practical, career-ready skills, and IUP has been proactive in shaping our educational offerings to meet these needs so our students can join the workforce and continue in the workforce. This includes some of our most popular majors, which are also some of the most important career fields that Pennsylvania needs the most. Nursing, teaching, science, technology, engineering, math, STEM fields, business and finance, safety sciences, cybersecurity are among those top majors that we have here at IUP. And part of the IUP journey for our students is experiential learning, where we strive to give our students practical, hands-on opportunities to learn and to do. And this often sets our students apart when they join the workforce. They're ready to go because they've already been working. Just proof of our impact, in the past 25 years, IUP has graduated more than 10,000 teachers, 12,000 business professionals, 3,000 nurses, and 9,000 students in STEM fields, serving the Commonwealth. Again, most of those students will end up working in this state. I have to brag that throughout our history, IUP has been a leader. We're not a follower. We're not the first state normal school, the first state teachers college in Pennsylvania, but we were the first of those schools to achieve university status and start offering doctoral degrees, and we did that in 1965, well before the others caught up in 2012. I love them all, but we were first. It's not something you get with an application. It was a long process with a great deal of public input and engagement and support from those that have come before you in the legislature, and we appreciate that. We were the first state system school to open a regional satellite campus when we opened our Punxsutawney Center in 1962. In 2024, we opened Kopchak Hall, hub of our STEM work, and many of you were able to see that wonderful facility when you visited us and toured yesterday. And it was thanks to incredible generosity of a couple of our alum who made the largest gift in IUP history to make that happen. I think that as we move forward, we continue to do wonderful things. You'll hear more today about what may be the most ambitious step that IUP has taken in a very long time, and that is our proposed College of Osteopathic Medicine, which connects directly to your topic today. We began this process in 2022, and we've moved forward incredibly well. You'll hear from Provost Luke Kahans and Dean Rose a little later, so I won't go into details, but I'll say that when this college opens, it will be the first of its kind at a public university in the Commonwealth of Pennsylvania. We're very pleased with that. It's not about attracting more students, although it will do that. It shows our commitment to this community and our partners to make sure that we provide a key element of the workforce to address Pennsylvania's rural healthcare crisis. And we're very excited about this. We're very excited about your support throughout. Once we're up and running, we expect our college will provide physicians, but also add about $79 million annually to our regional economy, increase jobs of all sorts, and of course improve healthcare and access to healthcare for Pennsylvanians in rural areas. So IUP's always been a step ahead, and we're continuing in that model. We hope to open and recruit our first students to show up in the fall of 2027. So I've talked fast. I know I've taken a little time, maybe more than you wanted, but I've given you just a little bit about IUP and what we stand for and what we're doing. But I want to emphasize that we can't do this work alone. We appreciate the support of our elected officials, you all at the local level, incredible people supporting our vision and helping us move ahead. And we're all in this journey together to make sure that citizens across the Commonwealth are healthy, can be well, and to move forward with everything we do. I thank you again on behalf of the university and our communities for being here and paying attention to Indiana and for all the work that you do every day. Mr. Chairman, thank you for this opportunity.
Thank you, President Driscoll. I think it's very clear you have a passion and a heart for service for the students and the staff that you represent. So I just want to thank you very much. Your passion is infectious. It's wonderful, the great work that you were doing here in rural Pennsylvania. Representing rural Pennsylvania myself, it's wonderful to see that there are people here that care so deeply just like you do. So thank you for being here today.
Thank you very much.
So while our testifiers come on up to the table, and I'll introduce you guys momentarily, I just want to mention what today's hearing is going to focus on, because we are facing a challenge in nearly every region of Pennsylvania, but one that is especially acute in rural parts of the state. We're seeing a growing shortage of physicians and other healthcare professionals. It's not just a healthcare issue, as the president referenced, it's a workforce issue, it's an access issue, and ultimately it's an affordability issue for families who depend on timely local care. So we're here today in Indiana County not just to discuss the problem, but to discuss the solution. Here we see a strong example of how higher education and healthcare institutions can work together to address a physician shortage in a practical, results-driven way. So I'm going to introduce our testifiers. We have got quite a few today. First, we're going to hear from Ariel Chordanoff. Wonderful to see you. She's the Vice President of State Advocacy at the Hospital and Health System Association of Pennsylvania. I also want to recognize we have several folks from Indiana University of Pennsylvania. We have Dr. Mika Rose. We have Dr. Laura Lutkehans. Thank you both very much for being here. Dr. Rose is the founding dean at the IUP College of Osteopathic Medicine, and Dr. Lutkehans is the Provost and Vice President for Academic Affairs. From the Indiana Regional Medical Center, we have two testifiers. We have Stephen Wolf, who is the President and CEO, and we have Dr. James Kinnear, who's the Chief Human Resources Officer, and we also have Dr. Kelly Meyer. She was born and raised here in Indiana County. She participated in the IRMC Family Medicine Residency Program. She's now practicing emergency medicine at IRMC. Thank you all very much for being here today. I understand not everybody will be testifying, but everybody will be available for questions. Just for members' information, you can make mic is on by tapping the button. Make sure the light is shining bright green. Please feel free to share testimony, 3 to 5 minutes, and then we will have lots of questions from the members. When we get to questions, all of you are welcome to just jump in. You don't have to answer every question, but you are welcome to answer any question. We are here to learn from you today. So we're going to start things off with Ms. Chordanoff.
Good morning, Chairman Rowe, Chairman Struzzi, and members of this committee. It's a tough act to follow, and I didn't know I was not supposed to be sitting up here, so I apologize if I took away from the welcome remarks. My name is Ariel Chordanoff, Vice President, State Advocacy for the Hospital and Health System Association of Pennsylvania, the advocacy organization representing more than 235 hospitals and health systems across the state. We're honored to be invited to join you today and fellow panelists to add our voice to this important and timely conversation. HAP's President and CEO, Nicole Stallings, was here in November as part of the Pennsylvania Mountains Rural Health Conference, outlining the critical role of hospitals in their communities and the amplified challenges that they face. These challenges, chronic underfunding, challenges recruiting and retaining workforce, outdated regulations, and a stifling medical liability environment are very real and especially pronounced in communities across the Commonwealth like this one and compounded in rural Pennsylvania. I'm here today to reinforce and to build upon Nicole's message that she shared in November. Strong communities need strong hospitals. People want to live in communities where they can access the health care and other services they need the most, such as emergency care, maternity care, labor and delivery, behavioral health. Businesses invest in and grow in communities with a healthy, local, qualified, and trained workforce. Hospitals do more than provide health care. They are foundational to local economies. Statewide, directly and indirectly, hospitals contribute about $196 billion to state and local economies. This is nearly 1/5 of the entire state's GDP. They support 1 in 8 jobs, generate about $62 billion in wages and other benefits, and on average pay about 7.6% higher than statewide averages for all other sectors. Thriving communities benefit hospital stability too, higher patient volumes, greater access to local qualified workforce, more patients with employer-sponsored coverage, which oftentimes pays above Medicare and Medicaid, as you likely know. Hospitals face significant financial headwinds as a result of chronic underfunding, payments falling well short of the cost of the growing cost of delivering care, and a variety of additional challenges that impact access and delivery of health care. Hospitals depend on Medicaid to keep our doors open, and Medicaid just doesn't provide health care coverage for people who are enrolled. It's how hospitals are paid for the care that's provided. For years, Medicaid, which is one of our largest payers, hospitals' largest payers, has reimbursed well below the cost of providing care, and federal cuts through H.R. 1 will make this shortfall even worse. Pennsylvania hospitals are reimbursed on average 71 cents for every dollar of care spent on a patient covered by Medicaid. Recent federal changes is expected to reduce this amount to 64 cents. So we're reimbursed today 71 cents on the dollar through Medicaid. We're expecting that to go to 64 cents, which is largely unsustainable for many businesses that you all know and potentially run. Hospitals are bracing for a sharp rise in uncompensated care due to coverage losses as well through Medicaid and through the state's insurance exchange. This trajectory is unsustainable. Just yesterday, an analysis by national consulting firm Oliver Wyman reinforced these challenges and outlined the consequences for our communities. The report commissioned by HAP finds that operating in a hospital in Pennsylvania is more challenging than anywhere else in the country. The report and summary materials have been provided to you. There's a one-pager that's been provided to you along with the report. It's manageable. It's about 15 pages, chock full of great information. Oliver Wyman's analysis found that Medicaid reimbursement to hospitals in the Commonwealth is 11 percentage points below the national average. In addition, Pennsylvania hospitals are strained by the highest per resident cost of medical liability payouts in the nation, as well as workforce shortages and outdated regulatory and administrative burden requirements that really strain hospitals' administrative staff. As a result, fewer than half of the Commonwealth's hospitals are operating with sustainable margins, and Pennsylvania hospitals have lower bond ratings than their peers, and 25 hospitals across the Commonwealth have closed over the past decade, and you all have seen this in the headlines. Federal action will worsen hospital reimbursement. The report finds that Pennsylvania hospitals were already at risk due to chronic and consistent underfunding, largely over decades. Without intervention, as many as 12 to 14 more hospitals could close over the next 5 years. This is through 2030. Adding 22 minutes to Pennsylvania's average drive time and costing $900 million in lost wages. Rural hospitals are especially at risk as they serve a greater share of Medicare, Medicaid, and uninsured patients. And hospitals' expenses continue to rise as these cuts come into place, more than doubling the rate of inflation. This is despite hospitals' best efforts to control costs and increasing efficiencies without compromising the care that they provide. Oliver Wyman's analysis found that hospitals have kept the cost per discharge almost 30% lower than in neighboring states. Despite these improvements since the pandemic, hospitals also continue to face significant shortfalls in their staffing. Hospitals report vacancy rates 19% for registered nurses, 17% for nursing support staff, as high as 30% for CRNAs, and 20% for surgical techs. In rural areas, as you can imagine, this challenge is even more compounded, with average vacancy rates about 20 to 21% across the board for these positions. Additionally, hospitals must navigate an outdated regulatory structure to deliver the modern care that patients come to expect today, adding an invisible to the consumer but very significant and unnecessary administrative cost that also delays care. Hospitals are not in a position to absorb the coming payment cuts, especially when the status quo is already underfunded and unsustainable. Funding through the Rural Health Transformation Program, which you all may be hearing about, will provide much needed support. Hospitals are appreciative of that support to invest in their workforce and their infrastructure, but it's not enough. It's not expected to be enough to offset the losses from the chronic underfunding and from what's expected to come down the pike due to H.R. 1. The RHTP will replace less than 25% of the Medicaid cuts due to H.R. 1, and Pennsylvania ranks third lowest in the percentage of funds restored. Expenses such as labor, drugs, and supplies continue to rise, and payments do not keep pace. Hospitals are already considering the future of facilities and services, and as you know, when hospitals close or are forced to reduce services, individuals, families, and communities feel these effects. Pressures increase on nearby hospitals and staff. There's delays in care as health conditions worsen. Emergency services either are largely overwhelmed or break down. Fewer jobs become available, and the community becomes, on the whole, less attractive for economic investment and relocation purposes. The status quo is unsustainable. Hospital closures and service cuts are a statewide crisis that invite statewide solutions. So while these challenges are real, solutions have been identified. We did a lot of the work for you, so we're happy to present those solutions to you here today. Solutions have been identified, and there is great opportunity to partner with state policymakers like yourselves to help stabilize our state's hospitals. First and foremost, ensure sustainable hospital payments that better reflect the growing cost of care and bring hospitals up to a more realistic spot with their payment reimbursements. Other approaches that are very real and achievable, we believe, to relieve the financial strain on hospital, enact medical liability reforms that keep Pennsylvania's in place and these high-risk services available, attract and retain healthcare workers through different incentive programs, and modernize regulations to empower and accelerate innovation. We stand ready to partner with you, with lawmakers, to prioritize these policies that keep hospitals open and services available in your communities. And thank you for the opportunity to amplify this information in front of you today, and look forward to questions.
Thank you very much, Ariel. For members' information, we had quite a bit of testimony today. We were not able to print all of it out, so your inboxes do have all the written testimony in there if you'd like to follow along on your phones. I believe Dr. Lutkans will be testifying from IUP, correct?
That's correct.
All you.
Thank you. Thank you, Chairman Rowe, Chairman Struzzi, and members of the Policy Committee. Again, I want to add my welcome to Indiana, to our region, and to IUP. We appreciate the opportunity to speak today. Again, my name is Laura Lutkans. I'm the Provost and Vice President for Academic Affairs, which makes me responsible for all of the academic elements that IUP offers to our region, to the Commonwealth. IUP is a public institution with a long-standing mission to serve the people and communities of rural Pennsylvania. And I'm pleased to be joined by my colleague, Dr. Miko Rose, founding dean of the proposed College of Osteopathic Medicine at IUP. We'll advance the slide. Pennsylvania is facing a critical healthcare workforce shortage, particularly in rural and underserved regions. This challenge extends well beyond physicians and nurses. It includes shortages in speech-language pathologists, radiologic technologists, laboratory professionals, nutrition and food science experts, and mental and behavioral health providers, the very professionals who make comprehensive team-based care possible. At IUP, we are responding with a coordinated, scalable workforce strategy grounded in partnerships, infrastructure investment, and outcomes. Next slide. IUP already plays a vital role in Pennsylvania's healthcare pipeline. Our nursing program alone produces approximately 120 graduates annually, with a 97% first-time NCLEX pass rate and strong retention and graduation outcomes. Similar strengths exist across our allied health and behavioral health programs, many of which are already operating at or near capacity due to workforce demand. Our graduates serve communities across western and central Pennsylvania, with most remaining in the same regions where they train, an outcome strongly supported by research and reinforced by our own experience. Today, we will share with you 3 of our strategic solutions to address Pennsylvania's rural health workforce needs. First, the proposed College of Osteopathic Medicine. This is a workforce multiplier for rural Pennsylvania. A central pillar of our strategy is the proposed College of Osteopathic Medicine, intentionally designed to serve rural Pennsylvania first. This initiative is not simply about producing more physicians. It's about strengthening entire healthcare teams and systems. Next slide. Osteopathic medicine is uniquely aligned with rural needs. Osteopathic physicians are more likely to enter primary care, practice in rural and underserved communities, and embrace a whole person approach that integrates physical, behavioral, and preventive health. That philosophy complements IUP's existing strengths in nursing, allied health, psychology, and community health. The proposed College of Osteopathic Medicine builds on IUP's established experience in doctoral education, applied research, and community-engaged scholarship. Approximately 1/3 of our undergraduate students are pursuing degrees in STEM-H fields. Our medical students will train early and consistently in rural clinical environments, participate in applied research focused on rural health disparities, and learn alongside students from other health disciplines in team-based care models. The proposed college currently holds candidate status with the Commission on Osteopathic College Accreditation. Importantly, IUP has already secured affiliate clinical agreements exceeding 240% of national accreditation requirements, with a strong emphasis on rural and high-need regions. These same clinical partners support training in nursing, laboratory sciences, radiologic sciences, behavioral health, and other allied health fields, creating medicine functions as a workforce multiplier, stabilizing rural hospitals and clinics while reinforcing the full spectrum of healthcare professions. Solution 2, expanding nursing and allied health capacity. In parallel, IUP has developed a 2-phase nursing program expansion initiative to increase the number of nurses trained, from an average of 175 students per cohort to as many as 350, depending on available funding through grants and private funding, while maintaining accreditation standards and educational quality. This expansion will be possible by creating a consolidated simulation training facility shared across nursing, allied health, and the proposed College of Osteopathic Medicine, strategic faculty preparation and hiring, leveraging affiliation agreements with clinical partners across programs, and dedicated student success and NCLEX preparation support. This same infrastructure directly benefits the other allied health fields, including speech-language pathology, radiologic sciences, lab sciences, nutrition and mental and behavioral health programs, all of which rely on simulation, clinical placement capacity, and strong hospital health system partnerships. Next slide. Strategic solution number 3, partnerships with hospitals and health systems. None of this work will happen in isolation. IUP maintains deep, long-standing partnerships with hospitals, clinics, and health systems, including Indiana Regional Medical Center, which serves as a cornerstone clinical partner for education, training, and workforce development. These partners help shape curricula to reflect real-world workforce needs, provide clinical and experiential training across disciplines, and serve as primary employers for our graduates. As we expand capacity across nursing, allied health, behavioral health, and medicine, these education practice partnerships ensure that students move efficiently from training to employment, strengthening local health systems and improving access to care. Last slide. Return on investment. These solutions are measurable, sustainable investments. By expanding coordinated training across healthcare professions, Pennsylvania will see increased workforce supply in high-need regions, improved retention of professionals in rural communities, stronger hospitals, clinics, and community health systems. In closing, Pennsylvania's rural healthcare challenges cannot be solved by focusing on a single profession. Care is delivered by teams, and workforce solutions must reflect that reality. With continued Commonwealth partnership, Indiana University of Pennsylvania stands ready to expand these pipelines, deepen hospital collaborations, and deliver a healthcare workforce prepared to serve Pennsylvanians now and for generations to come. Thank you for your time and leadership.
Thank you very much, Dr. Luke-Hans. From IRMC, who we having?
Steve.
All right, President Wolf, you're up.
Yeah, nice to meet you all. Thanks for being here. And I know my remarks have so much time, but I wanted to thank each and every one of you for your leadership for our state. You guys have tough jobs in a challenging time, and critics seem to be around every corner, but we really respect and appreciate all that you're doing. The HAP colleague, a lot of duplication in my testimony, which is written, so I'll do my best just to dovetail and not repeat, and I do appreciate my colleagues being with me here today. I don't have to tell you guys what your local hospital means to your community. You guys know what that means. And so my goal today is to try to hopefully see some, with deeper clarity, some of the things behind that, and then also just emphasize some of the strategies we think that could be really helpful for us. We provide a safety valve. I don't know that many of you would be aware that it's not uncommon that the urban centers have no room. There's no beds. We can't transfer a patient even if we want to. So that's a kind of daily thing, and especially when we come to seasonal events like we have now with flu and COVID and RSV, and certainly, God forbid, any more epidemics. But we really are like the safety net for providing care for our communities. Beyond that, as a former chair of the Chamber of Commerce, we know what it means to the economics of our regions and the ability to recruit and retain business and industry. Certainly education and healthcare are at the top of the list. And, we're really seeing some struggles across the state, as you're aware, with the OB deserts. I serve as a pastor up north near where Clint is, and my counterpart had to deliver his wife's baby in the back of his car because he couldn't make it to the hospital. That was just a couple months ago. It really is getting to be challenging, and we see more rural hospitals in danger of closing, and the jobs that go with that, the property values, emergency response, all the things that are around there. And we had statistics about the hospitals at risk. We are at jeopardy between Clearfield and here. I've been a hospital CEO for the last 31 years. I can't recall it being more challenging. Most rural hospitals never really recovered from COVID. And with the rising drug cost and labor cost and supply chain issues and demands for technology, it really is one of the toughest places in the country to be able to provide care. Financial stability is declining as we were kind of wrapping up our audit. Our auditors said, like nearly everywhere they go, people are in bond issuance, default. They have forbearance agreements in place. It really is a very, very challenging time, as I know most of my rural colleagues across the state. And we are grateful for the RHTP funds, but it is minuscule in what these additional cuts mean. And I'm worried how much of that will actually make it to rural hospitals. And the workforce shortage issues, which have already been talked about in nursing and EMS, behavioral health, and primary care. Literally every category is strained, looking for people in very many areas in terms of it. It's hard to recruit, it's hard to retain. And we see the regulatory and operational burdens just making things worse. Some of the kind of maybe just helping bring that into clarity a little more. There are significant compliance burdens with the DOH regulations. I know there's efforts to upgrade those, but they're unclear, they're slow, and even for minor facility changes, there's delays and additional cost. We have billing and credentialing delays. CMS, MA, commercial provider credentialing can take months, and we hire clinicians at high rates, and they sit around unable to provide care and bill for their services. We have restriction on integrating clinics and practices. Federal rules prevent us from combining operations that could reduce overhead, and transportation barriers are real, leaving many rural patients without reliable access to care, resulting in diagnosis delays and higher acuity. These may seem administrative in nature, but in small hospital, they have a ripple effect. So some of the things that we would like you to think about would be, increases to medical assistance reimbursement. I know what MA is to the state budget, and that's not an easy ask. And the Oliver Wyman report was mentioned by my colleague at HAP. I would encourage you to take a look at that. I mean, what hospitals in PA are making versus other states in the country in terms of medical assistance and commercial is really jaw-dropping. Many states, people are making multiples above Medicare in terms of what they're getting for medical assistance. And I think about the industries of the nursing homes and EMS and some of the changes that were made to provide vital funds for them at what was really a critical moment. We're there in rural hospitals, so we would ask for your consideration. Any gap-filling grants to offset federal cuts and help us cover uncompensated care, and protecting the 340B program through state legislation, preserving access to pharmaceutical drugs, and maintaining investments in our local communities. Secondly, anything you can be doing in workforce development for those pipelines, residencies, loan repayment, training partnerships, streamlining state licensing and credentialing processes so they can begin practicing and billing promptly, and supporting the EMS workforce stabilization through reimbursement increases and support. Third, just to support hospital infrastructure and technology. Any grants or any type of opportunities for scarce capital really go a long way to upgrading our facilities to keep us relevant, modernizing IT and cybersecurity. Fourth, to reduce regulatory barriers, to expedite the DOH approvals for routine facility modifications, work with federal partners to accelerate provider credentialing, revisit constraints on operational integration that could improve efficiency and cost, and also preventing additional layer of redundant and conflicting state regulations when federal regulations are already in place. That you would protect small and independent rural hospital funding distribution to ensure that the rural health transformation plans prioritize rural hospitals and who need it the most, that we have transparent oversight of funding, that it reaches those facilities, and that we support innovative strategies that sustain rural hospitals like clinically integrated networks and rural health transformation projects. And sixth, support community health and local transportation, that we would be able to fund health projects that reduce ER demand and expand transportation for rural patients who lack that reliable access to care. Support hospitals to effectively and efficiently transfer patients between locations like care home, trauma center, and higher level of care to avoid boarding of patients, which is a daily reality in most of our hospitals. So just in closing, I want to thank you for the moments to speak here today. I do believe you will cast a long shadow in terms of the future of rural health in our communities. And I just ask that you would help us to continue to be the anchors of stability, safety, and economic viability in the communities that you represent. We are committed to doing our part, working hard, but we cannot survive these unfunded mandates, the inadequate reimbursements, the crippling workforce shortages, regulatory burdens without strong partners in state government. So rural hospitals are not here for a bailout, but we need a sustainable path forward, one that allows us to help care for our communities and constituents and keep our communities strong. Thank you for your time.
Thank you, President Wolf.
Yep.
All right, are we going right to Dr. Meyer? Perfect.
Hello, everyone. My name is Dr. Kelly Meyer. I actually was born in Indiana Regional Medical Center here. Went away to St. George's Grenada for med school, and then thankfully IRMC was able to open the family medicine residency program here. And I signed as an emergency medicine physician, keeping me in this area. Super thankful for our residency program here. Actually, 5 of our 6 current graduates have signed to stay in the state of Pennsylvania. 4 of those being in Western Pennsylvania, 2 at IRMC, 1 at Punxsutawney, 1 at Armstrong Hospital, and 1 in Butler. So, like Dr. Wolf was saying, we have crippling staff shortages. I know in the ER working nurses are probably patient ratio is not comparable. And then to keep physicians here, they do have to pay a higher salary compared to those of the city but we're thankful for programs like RMC residency program, keeping a lot of physicians in our home communities here. So.
Thank you, Dr. Meyer. I wasn't sure who all had testimony. Dr. Kinnear, did you have any testimony to share with us today?
I don't have any testimony today. Be happy to help with Q&A.
Perfect.
Happy to help with Q&A. Thank you.
Well, thank you all very much. Before we move to questions from the members, I would be remiss if I didn't recognize Chairman Struzzi, who has done a lot of work helping to pull this together, who has been a tireless advocate in Harrisburg for this issue, and is someone who's definitely an expert in the field. I want to turn it over to him for some remarks.
Thank you, Chairman Rowe. I can't tell you how much I appreciate everyone being here today, all of you, all of my colleagues for traveling in some difficult weather, both tonight and this morning, for being here. Obviously, the rural healthcare issue is something that we're all keenly aware of and very concerned with. I wanted to have this policy hearing here today, and I appreciate the challenges that lie before us, but I also want to focus on the solutions that you guys are doing, I think, despite all of these challenges, and the success that has come from some innovative thinking, making the best of a difficult situation. Steve, if you could, and as I wrap up, I'd like you to talk a little bit about how you, IRMC, has, I guess, created this network of rural hospitals to maximize, your buying power, workforce, sharing services, that type of thing. Because I think it is going to take innovation. Yes, we have challenges, and funding is going to be very difficult to overcome, but we will work on that. And the policy side of things, as far as regulations, we all know we need to streamline, get rid of some of the red tape that creates those excessive administrative costs. So any type of information that you can share on those fronts, we would love to know. And hopefully in your testimony, there's more concrete things that we can do. But I do want this hearing to focus on the positives, the things that we're doing to overcome that. The School of Osteopathic Medicine, as you saw, is going to have tremendous impacts. Not just on workforce, but for the economy, for the future generations, for getting families back to rural Pennsylvania. And as was said, we had a great tour yesterday, and I appreciate everyone that put the effort into making that happen for us. But you couple that with everything else that's happening here in Indiana County with the Homer City Redevelopment Project, and we're going to have thousands of people in our community for the foreseeable future. And so that creates challenges, again, if we don't have the healthcare system in place to meet those needs. But again, our community, and that's why I wanted to share this with my colleagues, we are unique in that we truly work together to solve problems. The partnership with IUP, IRMC, with our community leaders, with the county, I think it is unique, but I also think it's a model that we can share and hopefully address some of these rural healthcare challenges that are happening across the Commonwealth. And then, Dr. Meyer, thank you for being here today. I think the residency program is just incredible. I've been fortunate enough to be at some of the graduations and I met you and some of your colleagues for several years now. And so I think that pipeline of getting young people back to their maybe hometowns and building a career, I think those are really good things that we're doing here, again, that can be replicated and with the state system, the opportunity there. And so, but I'd like to, if you guys could, I want to focus on some positive things that we're doing here. And Steve, if you could just talk about that sort of network that you've created through IRMC.
Yeah, I just want to say, to have a partner like IUP is really incredible. Dr. Driscoll and his team, and we are excited about the College of Medicine. And, a lot of times the reason a hospital emerge isn't so much finance up front. It really is the inability to recruit doctors. And so, the residency program is a solution that really has helped. And as you've heard, I think statistically nationally, about half of the residents that train in a rural setting will stay in a rural setting that's relatively close. And our experience has been a little better. So that's a positive in terms of it. We have put together Pennsylvania Mountain Care Network, which is the 3 hospitals of Armstrong, Punxsutawney, and Indiana. And I think it's been a neat way of coming at it, that all the communities still have representation and ownership of their hospitals, but yet we are collectively able to work together. And so Punxsutawney Hospital has doubled in size in 5 years. Like, nobody's doing that anywhere across the country unless you're in some exploding city somewhere. So real positive news for up there, and now Dr. Clark Simpson and the team do a great job there. Armstrong is only in about 18 months, but we're growing. We're able to have, more relevance in terms of our discussions with getting materials and supplies, working with payers, trying to, get into a clinically integrated network, things we could not do on our own, but just the collaboration between the hospitals and the sharing of best practices. I do believe that it's been a very positive thing and that we have a very positive future. We also are interested in trying to grow that, and so we are in discussions with a couple other hospitals about joining. I don't know, does that cover what you'd like me to cover, or is there something else?
How is that possible? How did that, I guess, what are the nuts and bolts of how that works? If you could just elaborate a little bit more.
So I think, a lot of credit to the hospital administrators and board leadership that we're able to, there's so much ownership and pride in a local hospital and having that local governance and wanting to try to maintain that, but to understand that the new local was more regional. So we do have a member substitution model that brought us together. And, the teams really work together well. We have a very strong culture. And, we see that with the energy that we have, we're able to attract physicians better. Because if you're coming out of medical school today, unless you have a compelling reason to go to a sole critical access hospital or a sole rural hospital, you're really worried about the longevity. So to see the three working together, we've really been able to recruit and retain not only physicians, but extenders. And we're never going to be any better than the quality of people that we have that are doing that. So I think that's been a big part of it. And then just, in the world that we live in, I mean, our relevance together, we're about $600 million between the three hospitals a year. I mean, it makes a difference when you go out to buy things. It makes a difference when you sit down with a payer about, trying to get payment rates that are fair to be able to care for your community. So I would say those are some of the nuts and bolts.
Yeah, that's great, Steve. Thank you for that. Again, thank you all for being here. I know my colleagues have a lot of questions, so I will pass the mic.
Thank you, Chairman Struzzi. Representative Nelson.
Thank you, Chairman, and I really appreciate the testimony from everyone. Trying to hold with the theme of Chairman Struzzi on keeping focused on positives, I may start with some concern points and then shift to some of the positives. We're always learning about ways to be able to improve rural health and, our really growing maternal health deserts. And, following that Pennsylvania Supreme Court decision that reenacted venue shopping, it's really created a lot of liability concerns. I think that could be a hearing in and of itself about how we could tackle that. So I'd like to focus on the filling the funnel, because I was extremely impressed in last night learning 240% clinical partnership capacity. Our daughter is pursuing, which many of the members know, her residency OB. Is very difficult to get back to Pennsylvania. I guess based on this match day that's coming for the OB partners, the entire state of Pennsylvania only has 98 slots. So last night I learned that Indiana County 4 OB doctors are all almost simultaneously retiring, creating a really there's two things happening. You have retirees, and then you have a shortage of being able to create those new slots. With your medical school, if we get it across the finish line and we're up and going, so exciting to hear that people are going to be accepted in there, how will we increase opportunity for residents to be able to start here?
So one of the first and most accessible ways to fill the immediate need is through things like the family practice residency and full scope of practice with family medicine. They are also we're in discussion with many different residencies across the state, not just IRMC, but a number, about helping them expand their residencies. And as a number of you have mentioned, OB-GYN and access to that is top of mind when we look at economic development and models of eds and meds and having the opportunities for families to grow, right? So families are less open or less likely to move and relocate if they don't have opportunities for OB-GYN services for their families. And so some of the models that we're looking at are family medicine and supporting academic infrastructure for an additional year where one can become a family medicine resident and then do a one-year add-on in which they would have full scope of practice in primary care and the additional training to do OB-GYN pretty close to full practice. OB-GYN, obviously, as your daughter's experience, gives full scope of practice, but then she's going to be limited on what she can practice in primary care. Some of the other models that we're exploring behind the scenes, and it's one of the beautiful things that we have with IUP, really this history of functioning as a glue between different hospitals, different healthcare organizations, and aspects of setting up creative models, is that we're starting to explore potential opportunities for partnership. So when I really did some deep dives with OB-GYN providers and hospital administrators about, like, what is the problem? Like, why are OB-GYN physicians, kind of like you're describing behind the scenes, they're just holding on for that next generation, and they're leaving en masse because they really have been holding on for many years and been wanting to retire, but not wanting to leave their communities and provide greater deserts of care. So there are things like FQHCs where the torts and some of the malpractice is not quite as prohibitive as it is, for example, in some of the privates and in the hospital networks. And so we haven't created formal solutions yet, but we're starting to really dig deep with providers, with practice groups, including folks at IRMC, Punxsutawney, and other groups across the state of Pennsylvania with a focus on rural to really dive deep into what's the administrative challenge of these OB deserts, and then what is the independent practice challenge of entering. It looks like med-mal is one significant part, not the only, but a significant, and we're starting to explore bringing partners together with IUP, sort of this academic forum table to create think tanks. How do we start to mastermind this problem and do something differently? Because we know with the trajectories we see, if we don't start encouraging different models for healthcare provision that starts at training with creative infrastructure, those deserts are only going to grow. When I started this role in November of 2023, after President Driscoll and Wolf had this beautiful vision of starting the medical school with this envisioned collaborative, there was an OB-GYN desert the size of Delaware. Now, since my tenure, just 2.5 years almost, it's grown to the size of Connecticut, and that's just in just over 2 years. So we know that this has to be top of mind in the infrastructure of our training and what we create with the hospital networks as well as graduate medical education. So I think it's going to be a multifold, multi-tiered aspect. I don't know if you have anything to, yeah.
Well, in following that, with the growth of the deserts, I think Center for Rural Health said 22 counties in Pennsylvania, maternal care deserts, and I've heard stories of deliveries alongside of roads. We've had turnpike drivers now deliver, ambulance people are delivering. I received an email at the beginning of January, Post-Gazette said Warren County is shutting down their only maternity unit. So the Medicaid side of things is very difficult. 14% of the budget, it's already over $7 billion. But your suggestion about targeted ways that we could improve, we had the legislature implemented Grow PA scholarships, which are extra incentives, $5,000 a year to fill the funnel for undergraduates in exchange for staying in Pennsylvania. Could we do a targeted, I know the residency programs, it's the first time that, Dr. Meyer, you get paid just a stipend, like $50,000 after all of these years. Could we create a residency stipend incentive for rural health so that if you're looking at a city school residency or a rural residency, $10,000, $15,000 makes a life-changing difference for you? How could we maybe target some incentives that are achievable and build off of like some of those existing successes?
Yes, exactly. And a lot of those training programs that Dr. Meyer's referencing, they're 12 to 18 months. Most of those programs are 1 year long, right? And then we have Ariel talking about some of the med-mal being one of the biggest impacts of our barriers to healthcare delivery. And we know of the specialties, OB-GYN is hardest hit. So I think it's going to be creative solutions and having funnels and funding opportunities for trainees to get that additional incentive. Once they're here in graduate medical education, we see that they have a much higher likelihood to stay in addition to where they receive their medical school education and clinical training.
So Dr. Myers, from your perspective, and I know, yes, Dr. Keener, as you look at getting offers, if there was an incentive for higher wages in your residency program or faster forgiveness, because it's tough, you get the qualification, but you have to work a long time to get that loan forgiveness. So how can we help in a short-term manner?
I think you're spot on with that. I know comparing residency programs, Indiana towards Altoona even, which is UPMC associated, was a 10 grand difference. So a lot are pulled towards Altoona, Pittsburgh areas instead of these rural areas. So building residency programs and having that rural stipend would be a very good solution to bringing more physicians to residency programs, where residency programs are what maintain physicians.
Thank you very much, Representative Nelson. Representative Barton.
Well, thank you, Chairman, and thank you, everybody, for your testimony this morning. And I applaud the vision that's becoming reality of your proposed College of Osteopathic Medicine. I serve Schuylkill and Berks counties, which is about 230 miles east of here, in very, very rural Pennsylvania. And I shared with some of you right before we started, we partnered with Temple University on a rural dental clinic. And there's 3 dental schools in the Commonwealth, all in the cities, right? There's 2 in Philadelphia, Temple and Penn, and 1 in Pitt. And so rural dentistry, like rural healthcare, and they're one and the same, right? As we share that, is difficult. And one of the things that we've been struggling with is, in our program, I'll just share with you quickly, it's 3rd and 4th year dental students will be attending in Tamaqua, Pennsylvania, a Temple Dental School. It's 10-year, much smaller than what your program will be. 10 students will graduate per year. So 10 3rd year, 10 4th year, there'll be 24 seats, but what it brings is 24 dental chairs to a very rural Pennsylvania. And I guess when I start thinking about, okay, now we have them here, how do we keep them in rural Pennsylvania? And I guess maybe a little bit of redundancy here with some of Rep. Nelson's questions, but my guess is medical professionals, it's not always where they want to practice, but sometimes their spouses, sometimes their families, sometimes where they grew up, sometimes their heritage, that it's not necessarily that I don't want to practice in rural healthcare, but my husband or my wife really wants us to live in Allegheny County or Philadelphia County or the collar counties of those areas, and not necessarily central Pennsylvania. They don't want to live in the boonies. And they want the metropolitan schools and the lifestyle. The residency program sounds like a real success. So I have another part of the question, but for this part, how do we do that? How do we keep the people here? And not necessarily right here, but in rural Pennsylvania, how do we give that incentive to rural healthcare?
You know, part of our concept for our solution is maybe less about some of the short-term incentives or looking at any one part of the training, but really beginning with future physicians thinking about a career in medicine and working with them all the way through residency and then where they elect to make their careers. And so for us, it's we feel like we have a lot of the ingredients that would really help us think about that. So I'm going to let Miko talk a little bit about understanding some of the characteristics of people who tend to practice in rural areas. But in addition to that, we're really excited to be part of the PASHE system that is primarily situated in rural areas, and partnering with our sister schools in PASHE to help build a pipeline of folks coming from rural areas across the Commonwealth who have interest in returning to those areas. Another ingredient is in how we recruit students really into even the undergraduate level and helping them think about a career in medicine in a way that maybe they didn't think was a reality for them. And so that's removing a lot of the barriers around accessibility of medicine as a career, including affordability. And so again, that's an important ingredient as an institution that's committed to high quality at an affordable cost, is keeping that with our medical school as well, trying to keep that tuition low. And again, that's an important part of, I think, a potentially Commonwealth investment in that. Then I think it's building this incredible network. So we've been really excited about the receptivity of our healthcare and hospital partners who are interested in collaborating with us. So that clinical training in the 3rd and 4th year of medical school, being situated in rural environments, builds that confidence and familiarity of staying in a rural environment. And then if we have sufficient residency seats, that they can stay and practice and continue their training in those residencies. So to me, it's the whole continuum of training that has to be aligned in order to really build that pipeline, not the one-shots along the way. And I'm sure Miko has more to add.
Yeah, so I was duly appointed prior to this appointment here at IUP at both Michigan State University, where I was focused on a number of aspects of medical education training, peak performance, and actually sports psychiatry, as well as my second of the dual appointment was at this rural-focused medical school in Washington State. And these models that we see of trying to, if you will, as you're referencing, almost like convert people from urban and suburban areas to consider replanting themselves in rural areas is kind of a hit or miss model. What we see have been incredibly successful, and the national data has no refutation, is that there's not really refuting that these grow your own models are very solid and powerful. And I can say, having been in a number of rooms of medical admissions committees and what they're using as criteria, they're not focusing as much on secondary characteristics, meaning the non-numbers of MCAT scores and grades, as leadership, service. Many of our best service-oriented, rural-focused physicians in medical school will tell us that they're first-generation physicians, and many of them are first-generation undergraduates. At IUP, we have 50% and 50% first-generation undergraduate, and that number fluctuates as sometimes higher. And when I was in a room with a number of IRMC osteopathic physicians and asked all of them, how many of you are first-generation physicians? Every single hand in the room went up. So we know that there's something to being first-generation around this model of grow your own. Some had come from other regions, but they were from other rural regions and moved with a family member. We know that 90% of our students come from Pennsylvania, as President Driscoll has referenced. So even if they relocate and meet the love of their life and relocate to another rural region in Pennsylvania, that's still a win for Pennsylvania. So what we're seeing is that the national models of Grow Your Own are very successful, and we have some targeted different approaches and measures to focus on inspiring potential first-generation physicians to consider careers in medicine and then utilize the existing academic infrastructure and support that IUP already has outstanding, incredible support to work with first-generation undergraduate students. And then second, I'm working with the Center for Rural PA on looking at all physicians who are in current rural practice and seeing what are their values, what are their experiences, what are their backgrounds, just like in sports psychiatry, of really figuring out what are the secondary characteristics of picking the right values and characteristics so that we can start to identify traits and characteristics beyond scores and numbers to determine who are those students who are most likely to stay. There's not a whole lot of data on that, and that's what we're looking to create.
I like your grow your own model, Ariel.
I was just, just to kind of bring that full circle, the grow your own model, we really like the idea of the residency stipend. You all, just to talk about the positive things and things that have been done, House Bill 157, it was Chairwoman Kathy Rapp's bill. It was a rural loan incentive program, or rural loan repayment program, but really getting folks attracted. When we talk about workforce attraction and recruitment and retaining the workforce, really attracting students to those areas with the stipend program, and with something like the stipend program as you're envisioning, and then keeping them there with the loan repayment, in addition to I love your term, the grow your own models, really would, I think, help full circle attract folks to these areas. And then to the point about meeting folks, I think once you're there for a couple of years, you end up entrenching yourself in the community, and hopefully the community has those supports, and you want to stay, you want to buy a home, you want to send your kids to school in that community. So just wanted to add.
Thank you. If I may, Chairman, another piece that, Mr. Wolf and Ariel, you both spoke significantly about and highlighted the outdated regulations and the regulatory difficulties that struggle healthcare across the Commonwealth. And Pennsylvania has 22% more regulations than any other than the average state in the United States of America, and that's significant. And certainly all across the regulatory environment in PA. And Ariel, you spoke about sustainability payment reimbursement and sustainable payment reimbursement and medical liability reform. And Mr. Wolf, you spoke about significantly a long list there. And you got to forgive us because I'll speak for myself. I'm in the energy business. I'm a coal miner, and that's my background. And we all have different backgrounds as legislators. So sometimes hearing repetition helps us understand this better, at least for me. So are there regulatory burdens that are at the top of the list? Are there things that we should be really hitting first, that boxes we should be checking to make sure that we're taking care of rural health care and health care in general across the Commonwealth?
You're better positioned to speak to the actual, I have anecdotal information about, putting windows in and waiting 3 months for approval. Any type of modernization to the facilities, which, as I mentioned in the testimony, we all walk in and expect to have modernized care. So some of these really antiquated regulations are just beyond. I will say there is an effort underway to revamp these regulations. That's no easy feat, but what HAP has been really trying to highlight is the strain that it puts on the hospitals and on facilities and on rural communities, specifically because you might not see it. Your patient, the average patient wouldn't know that there's a delay, but you might call and you might wait 3 months for an appointment, and it's because they're waiting for approval. So HAP is really trying to highlight the fact that these regulations may be invisible, but there's a very real cost in terms of financials and also patient delay. And also what we're trying to do there is get some momentum behind legislation to really look at the cost impact of the outdated regulatory structure on Pennsylvania hospitals. So you might be seeing more about that hopefully in the coming months, but we are very much focused on it. We know that idea, that concept gets a lot of traction in other like energy, when you talk about permitting reform and faster times to actually open your doors. The same holds true for hospitals, and we're just trying to really educate the public on that and educate lawmakers and anyone really who will listen about something that's really not, it's not making the headlines. Regulatory burden or administrative simplicity is not making the headlines, but we'd really like to bring it forth as something that's part of the conversation.
If I could just add on, I'm on the HAP board. I think HAP's done an incredible job on this. So we've called all the hospitals and we've prioritized the biggest things that we want to have in the regulation review. And I'm sure we could get that information to you so you'd have our priorities. Does that sound good?
Perfect. Thank you very much.
Secretary Howlett.
Thank you, Mr. Chairman. And I believe that there's a renaissance around rural Pennsylvania. I think it's coming back. I think the interest is there. You see it in a lot of different other aspects other than just healthcare. The problem is going to be is if we don't have great healthcare opportunities that make it through this shift that we saw. But I think that things are moving back in the idea of rural lifestyle and the pace. People want it. The next generation is looking for it. And I'm excited to see, what that's going to mean for healthcare as well. And we have to be ready for that. So I did have a question on the nursing. And a couple of statements. I love Grow Your Own. And I believe this in all different aspects of life. But if you have the right team, you can build whatever you want around the right team. It's all about the people, making sure that you have them in place. And then you can build a hospital system. You can build a factory. You can build whatever you want around the right people. Thinking about the nursing program, you talked a little bit about that. So maybe from the IUP's perspective, looking to grow that, how are you looking to feed that from our high school students, and when's the best time to attract them into rural healthcare? And is there an opportunity maybe to take a nurse and move them up the ladder? I was in an EMT meeting last night, and how they really focused on trying to move them up through the ladder into the system, deeper into the system. What are we doing at the high school level to attract students? There's fewer of them, so we have to be very strategic in how we're marketing to them. But in the healthcare industry, what are you doing in that aspect, and what's the progression moving forward through the system?
Thank you. I think that's a great question, and we are focused, just as I talked about with folks that might be considering medicine as a career, we have efforts in the other healthcare areas as well. Particularly in nursing and other allied health areas, we are really focused on dual enrollment. So we are fortunate to be among the recipients of a state grant that invested money in IUP to help us build a dual enrollment program with high schools that focus specifically on healthcare careers. So that's something we're just launching now with the funds that have been released this fall. And through dual enrollment, we have high school students who are able to dabble in some of those related classes that are easily articulated then as transfer credits, college credits, and make college more affordable because they're able to get the dual enrollment credits at a lower cost, and then it shortens their time in college. So that, I think that's one strategy. Another is we work really closely with our regional intermediate unit and our partners in career and technical education to introduce health care careers. So this will be our second annual in February, where we are engaging our local area school districts in Armstrong and Indiana counties to explore healthcare careers at Lenape Tech in Armstrong County. We have representatives from our great team at IUP, from our great team at IRMC. It's something that we work on with our partners from ARIN-IU, IRMC, and IUP to build and bring really exciting and engaging activities to that high school audience so that they could start to imagine what it would be like in a healthcare career. And then as a follow-up to that, we have an extension where we invite both high school students and high school guidance counselors and teachers to IUP in early summer, and they get to dive in a little bit more deeply. And we have parallel tracks that help support the educators so that they can continue some of that interest and excitement around healthcare careers and share that with their future students, as well as the students who are right at the cusp of thinking about college and gaining this experience. And then I would like to add to that, I know our colleagues at IRMC, for example, also offer some programs for early career or for exploration that can be pretty competitive. And so we've talked a lot about how could those be expanded. But before I even jump to that, I would like Jim to share some of the great things you do with those programs.
Thank you. I want to just first echo that I do think Indiana is in a very unique and fortunate spot to have the great partnerships and relationships we have, not just between the hospital and IUP, but also with the entire educational community, and a really strong partnership with the intermediate unit and our local schools as well. And when we think about Grow Your Own, I mean, that's definitely one of my favorite topics, because I think that answers of how do we attract people to work in a rural community. You start with the people who grew up in the rural community, because they're embedded, they have family, they have lives, they have a sense of identity that's connected to being part of that community. And they have a natural, willingness to want to give back to that community in some way. So that's where we really want to start. And I think building that strong high school to healthcare pathway of how do we help people, not just in medical college, but the whole realm of health careers, find what opportunities are out there and how they can pursue those opportunities, and make sure that that's something that we're attracting their interest in, and we're providing them the resources to pursue that. In addition to some of the programs that Dr. Lugohans was mentioning at IRMC, one of our programs is a summer program that allows high school students who are interested in becoming a physician to spend 2 weeks. And they spend 2 weeks shadowing, working alongside with physicians, getting a chance to see what it really means to be a physician and having that early exposure and experience. And that really builds on other types of shadowing programs that we also offer, but this is obviously a much more intense experience and allows them to get a greater sense of what that looks like. We also have a summer program for students that are pre-med students to come and also spend an extended amount of time in the organization to understand what it's like to work alongside rural physicians and understand that career choice a little bit further and help them as they're preparing. And important part of that is building relationships, because that gives an opportunity then, for students who, later we see that person coming back and applying for the residency program or applying for other positions, because they remember that experience and they formed a connection and a bond and they wanted to continue that further. So it's just not one type of transactional experience. It really is about establishing relationships and building relationships. I think in addition to the high school component, and I think, you know, for schools in general, the literature would support you cannot start too early. So in terms of when do we start trying to get people interested in health careers, as soon as possible. And earlier grades, it's really just generally getting people interested in the field. What does it mean to work in healthcare? What is it like? What values are important to that field? And it doesn't have to be a specific occupation at that point in time. And then as the student progresses, it's an opportunity for them to get more narrowed into their interest in saying, what might that look like for me? What particular job is attractive for me? Beyond the high school and the school components in general, I think we also have to look at another important part of our workforce are people that are maybe non-traditional learners and students. And maybe they're in another profession today, and they would be someone that would be interested in a health career, but they can't afford to quit and not have income in order to go and pursue that health career. So I think there's been some, you know, innovative ideas out there in terms of apprenticeship type programs where, for example, someone might be hired as a nursing assistant and be paid for their nursing assistant role, but while they're doing that, they're getting training to pursue a higher nursing career and building those career ladders. So it gives them the security of income while they're learning, and then it also gives them an opportunity to advance, you know, into their profession. So we have to do everything, you know, so we want to attract those high school students, but we also want to look at people that are currently in the workforce and see how can we introduce them to the healthcare field and how can we help them advance in the healthcare field as well.
Thank you so much, and I totally agree. You can't start too young. We have to start early on, attracting them to any type of profession, and you're engaging in that, and thank you so much for that, and thanks for the update. Thank you.
Thank you, Secretary Allett. Chairman James.
Thank you, Mr. Chairman. Thank you all for the testimony. It's quite enlightening, frankly. I have a whole bunch of questions, but let me just throw one at Ms. Chartnoff first. You began the morning with comments about the rising costs that we have not been able to cover for a variety of reasons. It would be very helpful to us if you could give us the top 3 cost drivers, then one for Dr. Rose. I think it was you that mentioned that there is a study going on now about antiquated regulations. I'd love to find that information out, and I'd probably need to talk to a warm body, not just get it in writing, because I wouldn't understand it. And then finally, for anybody, is telemed working? If yes, great. If it isn't, why isn't it? Then I'm done.
I can take the first part of that question. We did talk about all the cost drivers. I would say there's a few that come top of mind in addition to the sustained underfunding. Okay, so we established that. The regulatory complexity, as you mentioned, I repeating myself a little bit here, but it's an invisible. Yeah.
Let me interrupt.
Yeah.
You're talking about a supply of money. I'm asking, what are these costs? That's my question.
Oh, you want numbers?
Not numbers. Well, maybe numbers, but I mean, is it doctors demand greater salaries and nurses? Is it technology that's a problem? What are the problems as opposed to us not giving you enough money?
No, and the regulatory piece is not about money. It's more about doing less or modernizing things. So I was going down the route of the regulatory complexity is an invisible cost driver because there's delays in care and there's staff time that's been spent towards navigating that process. I would also say rising drug costs and equipment. The workforce is a driver, and I wouldn't frame it in terms of doctors demanding more, but the cost of living, as you all know, is increasing, and to get doctors and qualified staff and the support team to these areas and to keep them in these areas, you really do need to pay adequate salaries and benefits and other incentives that keep them in that area. In addition to that, I guess I would be remiss not to really put a finer point on the medical liability component. A lot of these costs, we have some quantified numbers in the Oliver Wyman report that you have, but the medical liability cost is very real. We have the highest per resident, Pennsylvania has the highest per resident payout across all states. That's a very real figure. And it's really driving a lot of decisions financially, workforce-wise, when you have those types of risks to consider as you make decisions. So technology, supplies, drugs, workforce, medical liability. Sorry.
Yes, and Representative, so the areas was this under AI or medical education admissions or a different study? Because I know you asked me about
the
AI
antiquated regulations. I believe it was you that said that there's a study or somebody is looking into it. Maybe it wasn't you. Maybe it was.
I think Ariel was talking about antiquated regulations, and then I was referencing medical admissions processes. And I'm working with the Center for Rural PA in a study to survey rural physicians in practice and whose licenses.
And to correct that, we need to know what those are, because we're not physicians or nurses for the most part.
Yes.
We are.
Comment on that. The antiquated regulation. The antiquated regulations.
Others, sorry, I feel like it's back to me again. Others can chime in as well, but yes, I did mention a study that HAP is trying to really get some momentum behind to quantify the cost of the outdated regulatory structure, the cost to hospitals because of the outdated regulatory structure. So you will see that. That's maybe what you had heard. Yes.
I would say telemed is working. It is a very viable solution for rural healthcare in terms of being able to reach, and particularly with workforce shortages, being able to bring expertise to areas. The biggest challenges for healthcare providers with telemed is, the reimbursement doesn't necessarily keep up with the cost of providing that service otherwise. So it is a great solution to have that technology, but there's still a funding gap in making sure that it's something sustainable to offer to healthcare organizations.
I can also just comment, having been a provider of telemedicine, particularly in psychiatry, where I was frankly a little bit skeptical of my ability to connect with patients over telemedicine. And it was a phenomenal way to connect with patients who had little to no access to care. And it was a very powerful tool. We are now seeing, especially in some of the rural areas, telemedicine is also, for a physician-to-physician or provider-to-provider consult, also very effective to be able to have direct, telemedicine consults, if you will, not just the provider to the patient, but provider to provider. So when there are things like emergency OB situations and a family medicine doctor is kind of hitting the edge of their practice limits of expertise, I've been to some rural hospitals where they can actually telemedicine consult and have OB-GYNs hop onto the computer and work side by side and coach that physician into how to have successful deliveries, do complicated and unexpected interventions. And I think, I think it's been referenced before, I think with the right teams, the sky is the limit, because the access where there is none is just a very, very powerful tool.
And I would just like to add a perspective from the consumer point of view. So I think you're hearing it from a provider, but we've been working on some projects to help build digital literacies and ensure that we have the last mile of broadband to individuals, because accessing telemedicine is still an issue. And so, and then I think there are also training and literacy opportunities, not just in terms of how to use the technology, which is important, but also trusting telemedicine as a viable solution. So I think there are sort of lots of social and other sort of technology access issues that we would have to think about as a part of a telemedicine solution.
Thank you, Chairman James. We have Chairman Marty Causer online. Chairman Causer, you're up. Chairman Causer, we think you're still muted. Might be a problem on our end, Chairman Cause. We still can't hear you. Chairman Cause, can you hear us okay? Chairman Causer, would you be able to try jumping on your phone? They're not sure if it's our end or your end, but if you could jump on your phone maybe and try that instead of the computer, see if that works. And we'll come right back to you if that's okay. Okay. All right, while he jumps over, I do want to recognize we have been joined by Chairman Doyle Heffley of the 122nd District. Chairman, thank you for being with us. We're going to jump to Representative Leslie Rossi.
Thank you, and thank you all for coming to talk about all these important issues with rural hospitals, because in my district, that's the #1 employer. So when we talk about addressing high school students and trying to get people to stay rurally and locally, you know, I'm worried about the outreach not being enough. I think we tend to focus on we need doctors, we need nurses, but we also need other workers in other areas. So I wanted to know, how are you getting, if you're doing the shadowing program, how are you obtaining those students? Because I think if you're reaching out to teachers, they know the students the best. I would like to see some of the worker bees get those opportunities, because I'm aware of several students that don't have a 4.0 that just aren't getting opportunities, and then that door's shut. And if you don't necessarily have a nurse, doctor in your family, or you don't have health problems in your family, you're not exposed to a hospital. But what a great place to work. Socially, there's many people you build relationships with, you care about the community. It's deep-rooted. And so I want to reach other people, and so I wanted to see if that was a focus where we're trying to, you know, if you have a student that's an average student, they could be a tech, or they could, you know, possibly could you reach out to the VOTech where those kids are coming in and working in the cafeteria, or even maintenance. You know, when you think about they have to do housekeeping, other jobs within the hospital that maybe aren't as high up as doctor or nurse, because although that seems to be the focus, it all interconnects.
Thank you for that question, and I think it's a great point that we want to attract to every healthcare profession and role. And you know, interestingly enough, one of the things with healthcare is there's a lot of positions that, you know, sometimes people might not think they want to work in healthcare because they don't want to do direct patient care. And so one of the things that we try to do is create awareness that there's a wide variety of roles in healthcare. There's many business office functions, IT functions, many other types of professions within the healthcare organization that are very critical to that overall delivery of care. But to your point in terms of how we're reaching that larger audience of students, I think there's a couple different ways that we're doing that. One is trying to be present in the schools and having individuals go out and do presentations. So, for example, the local school district has health career events and a variety of people coming in from different, you know, career fields to speak. So that's not isolated to just a certain group of students. So that's open to others. And we have, you know, individuals like respiratory therapists, medical coders, laboratory technicians going out, doing presentations, talking about what they do in their particular career field, so students get a sense of all the variety and options that might be out there. Some of the events that Dr. Lugohans was mentioning, similar to the event we have coming up here in February, where we're going to have students from basically every school district in Armstrong and Indiana County, and they're invited to spend an entire day at Lenape Tech, coming in and meeting a variety of different people. And it's, you know, in the course of the day, you might have a chance to see 10, 15, 20 different healthcare professions and set in on different, you know, informational talks and get exposure, again, to that wide variety of fields that are out there in terms of the healthcare field. We've partnered with the Indiana County Technology program as well, and we're doing student internships. So these are students that are in the technology school, and in their second or third year, they're coming out and doing internships and externships. So by the time they're graduating, even if they're not planning on going on to post-secondary education, they may be very well qualified to come into some of our entry-level professions and positions in the organization. I think it's something that we're proud of everything that we've done, but we know we need to continue to do more. Probably the biggest challenge with it is that it's a part of what a lot of different people do. and it's not always that 100% focus for one person. So I think more that we can do to build consistency and stability to, making sure that we're doing more of it over time would be very helpful.
Okay, and I have one other question. So as far as IUP, what do you do with students that just aren't making it? So sometimes you have a student that really wanted to be a nurse or really wanted to be a doctor or a physician assistant, and they're just struggling to pass, or meet those qualifications. I feel like we're losing them. I know of two students. One was super intelligent, and her issues were financial. The other one was such a hard worker, such a loving, caring person, and she just could not pass that final exam. And so instead of keeping those individuals in the medical field, one is now a lawyer and the other a teacher. They went off onto some other profession. And I just think, how do we, as college institutions, gear those individuals to do something still in the field, still working with the people and just going another route. Instead, I felt like both those students were just forgotten, and they were, looking at their mom who had no idea, who's trying to guide them. And are they happy today? No. When I talk to them, how's your job going? All they do is complain. So I think they really did miss the boat and not get into the profession that they wanted to, but they needed that little extra, or they were just, because we don't always think about what kids go through in college. They're away from home, they're broke, they're hungry. You know what I mean? They're just in a different environment. It's tough. They're trying to work, they're trying to juggle school if they're in a sport. There's so many things going on, and they miss it by a small percentage point or something, and boom, you just lost a perfectly good nurse that maybe just needed a little help.
Yeah. So actually, we pay very close attention to that group of students in a variety of ways. So upon admission to IUP, every student is assigned not only a faculty advisor, but also a navigator. And it's part of our student success infrastructure that we have really stood up a pretty intrusive approach to making sure that we are in touch with our students and that we are supporting them. Since we have done that, we have increased our retention rates by multiple percentage points each year, and so that's been very exciting institutionally. Within particular disciplines, we also have some focused efforts. So, for example, a student that might come into IUP might not right out the gate meet all of the criteria for admissions into nursing or respiratory therapy or any of the programs. We have a structure for exploratory students that helps them gear up and get good, intensive support to make sure that we can admit them. As I was talking about with nursing, and we have capacity in some programs, we're at full capacity at others, but I'll just use nursing as an example. We are at full capacity. We turn students away from admissions there. As you mentioned, if there are students that aren't getting passing grades, even with all the supports that we provide, there are people sort of behind them ready to be admitted. And so we know that if we want to expand that to the extent that I talked about, where we would essentially be doubling our numbers over a two-phase program, a major investment has to be in those supports. So again, IUP is really proud of our NCLEX pass rate. It's extraordinary, but we invest a lot in doing that with the numbers that we have. In order to scale that up, we'd have to invest even more. So that's a big part of the solution. And then I think the other piece that Jim and I have been talking about is trying to give that exposure to a range of careers. It isn't just doctor and nurse, and there isn't only one pathway to either of those professions either. So trying to think about multiple pathways for students because their readiness may be at different points. Even thinking about the physician pipeline, we have students that might grapple with, gosh, I really love art and music. I'm kind of interested in medicine. And we're asking ourselves, well, do we have to make them choose? Can we create a pre-professional program that would fit well with a music degree as well as with pre-med? And so we're looking at, again, across all professions to try to improve and increase the pathways that students have. Another example is we have an LPN to BSN program that takes some of those students that might have gone through career and technical training or practicing LPNs and help them achieve a BSN credential. So those are just some of the examples that you've mentioned. I think healthcare, the range of professions really struggles with sort of a marketing and awareness issue. People have very narrow understandings of what some of the opportunities are, especially new students coming in that don't have a lot of exposure or they're first generation, and they only think of a small handful of opportunities. And so these high school, middle school kinds of exploratory experiences are so powerful in broadening their range and helping them think about what some of the opportunities are. And I know that in our collaborative, we've focused mostly on the credentialed pathways because that's what IUP does. But I think it's also interesting of what you brought in terms of the full range of careers that are available in hospital and healthcare settings that maybe don't require a credential, that I'm sort of filing away to think about, are there short-term credentials? Are there other kinds of things that we could be partnering on to help prepare a workforce for some of those other paths? Yes, please.
I have a quick thing to add just before. And then for the College of Medicine, as an expansion of that, we know that a lot of students will need additional academic supports. When we look at some of the rural tracks in other medical schools, they actually said that the greatest need was, like you're referencing, psychological support for those culture changes and the big shocks. So it's an extension of IUP and the existing program that will be teaching students how to study for those more challenging exams, and it'll be very similar to the rest of the infrastructure.
And just quickly, because I know we're at time and we have a chairman question, I'd be remiss if I didn't mention it did this year an inaugural virtual career day, which is, I think, more of a grassroots initiative than some of those really, really robust programs that are in place today. Through the medical schools, but we went in and we not me, but the program was put together. It was pushed out through school counselors, through school districts, and it was really talking about all of those things. When people think, like, what do you want to do when you're older? I want to be a physician. I want to be a nurse. There's as you said, there's so many other professions on that scope. HAP went in and did a virtual career day. I think over 100 schools participated. So it's likely, I don't think it's a stretch to say that there was thousands of lives that were at least spoken to virtually. And we're going to be looking to do that again next year. And we'll be in touch with all of you on how to better share that throughout your communities.
And I just have one final question, and thank you for all those great answers. What are we doing about the travel nurse issue? Are you still using those as much? Because that's a really big complaint I get. So we have nurses that have worked in a hospital setting for many, many years. They're making a certain wage. They get these young traveling nurses that float in, make double what they make. They don't know what they're doing, and they're cocky. I hear it over and over. And so the interesting thing that, I find is when you talk to a young nurse just coming out of school and they're excited, what's the first thing they say? Oh, I'm going to be a traveling nurse because I get to go everywhere. I have no ties and I'm going to make a ton of money. But I'm finding it really causes disruption within the hospital because these loving nurses that have dedicated, have poured their blood and sweat into our rural hospitals, they aren't making what those girls make. And, they say, oh, well, they don't get the benefits or they don't get this. I think that during COVID, we really saw that craziness go on. I just sort of would like a gauge on where is that now?
I could speak to that a little bit. I think first I would just say that we don't like the cost in terms of the pressures it puts on us to have to pay those agency fees and have that additional cost. So we would share in that goal and that vision of really eliminating that need to have to rely on travel and agency staff as well. The good news is we are seeing it go down significantly. And I think most of the organizations I'm familiar with, we're relying less and less on traveler and agency staff. And also the cost of travel and agency staff is variable based on demand. And as the demand has gone down, some of those costs have reduced as well. So I think we're headed in an overall positive direction and seeing that move the right direction. But it gets to the key issue is the way to address that issue is to reduce the need by increasing the supply of other individuals that are in those positions. The only reason we use travel staff is because we're unable to fill some of our other staffing positions. And it is always a little bit of an employee dissatisfier because of the wage gap and the difference. One of the things we do try to share with employees that we acknowledge that, but it also is for their benefit and for the benefit of patients, because we're trying to figure out how to manage the workload at the same time. So I think the more that we can do to address the workforce shortages issues, then we're going to see that condition with agency nurses continue to improve. I was thinking about this a little bit today, and just kind of a mental model that I think kind of captures a lot of the issues going on in rural healthcare is it's kind of a Bermuda Triangle. And if you imagine the demand for healthcare at the top, we have an aging population that demands more care and more complex care. We're seeing trends for the need for more behavioral health services. So we have a lot of demands coming on to healthcare organizations. At the bottom of the triangle on one side is the workforce shortage issues, not being able to fill some of those critical vacancies, seeing people retiring faster than what we're able to recruit back into those positions, having a lot of pressure for wages for those, because we're competing with large urban healthcare systems that are able to pay more than we're able to pay. And so it creates a constant challenge. And on the other side, there's just the overall financial challenges with reimbursement, higher technology costs, higher supply costs. So we can't fill all those positions because sometimes we can't meet some of what the larger urban healthcare systems are paying for those jobs, which creates staffing issues and challenges for us, and then we have to go get agency staff. So we continue just to kind of work around those challenges around that triangle, and we just have to look at more solutions to address some of those things as part of correcting that overall.
Thank you very much.
Thank you, Representative Rossi. We are going to go back to Chairman Causer. I do want to say we've got about 10 minutes left. We've got a hard stop at 11, so let's keep things concise. Chairman Causer, you're up.
Thank you very much, Chairman Rowe. Can you hear me this time?
Yes, sir. We're good to go. Thank you for your patience.
Thank you very much. I appreciate it. And I want to thank everybody for the testimony today. It's been very informative. I have a daughter that's over at Lecom Medical School, and she recently toured the Indiana Regional Medical Center, talking with you folks about your residency program, and she was quite impressed. So thank you for all your work. My question centers around the federal money that's coming to us, and I'm in an area where I'm in the heart of the OB desert. The 8 counties where there's no place to deliver a baby. We're having babies delivered on the side of the road in ambulances, and unfortunately we've had babies pass away. So it's a critical issue up in this region. And I'm thinking about the federal money that's coming to the state, and I'm concerned that it may be diluted. And my question centers around how can we make sure that we're using this money to make the biggest impact, from your opinion, in tackling the challenges that we face in rural PA?
Yeah, I can take that. And in staying being concise, we are expecting, the state is expecting $193 million this year from the Rural Health Transformation Fund. We are of the same mindset, Chairman. It's not going to be enough. We're grateful for it. Anything is helpful. It's not going to be enough. I think you heard me say it's. I think Pennsylvania's third in terms of the deficit that these dollars will make up, and we'll get that year over year, but only for 5 years, and that will go quickly. We also understand. I represent HAP. We're partial to hospitals. We want all of that money to really be funneled to our hospitals. We know there's partners that we have that also are eligible for those dollars. So I don't know that I use the term dilution, but we understand that hospitals are not the only recipient of those dollars. And we do have a team at HAP that's working on this with the administration and with DHS and DOH, trying to be good partners with them and trying to learn as much as we can along the way. We understand that there's a plan for rapid response grants to go out this year, and while they are standing up these rural care collaboratives that are maybe to your point in terms of prioritization, They're made up of local business leaders, lawmakers, educators, folks who really know their community, which I think really underscores everything that was talked about today in getting those dollars out to the entities that are most in need. So that's as much as I have that, that might be helpful in terms of the dilution piece, but we are doing everything we can to make sure that they get to the folks who really need it the most and being part of that process.
Thank you very much for that. I certainly believe that we need to look at all regions of the state and try to figure out a solution to how to maximize the use of this money, to really look maybe at each region and what's missing from that region. I can say in the northern tier, OB is certainly a huge one, but we've got many other issues, and I just would like to work with folks to make sure we maximize the use of the funding. So thank you very much.
Thank you, Chairman Causer. Representative Armanini.
Thank you, Chairman. And I'm probably the last one here, so we'll make it short and sweet. Thank you so much for the valuable information that you've presented to us today. My question here is, everyone sitting here, we are rural Pennsylvania. You've brought solutions to the table. Can you help us move forward with legislation that will begin to fix the problems that we are facing in healthcare? I'm ready to work with you on any legislation present. I believe this is something that will, spread like a wildfire. I'm sure all my colleagues are on board with me on this, with all the other rural representatives and senators, statewide who are not present. I think it's time we start moving. We've been discussing the problems not getting any easier. And I thank you for really, in my eyes, bringing it to light to say, let's move, let's go, let's start helping ourselves, because rural Pennsylvania, as my colleague here, Mr. Outlet, has said, people want this type of life, but it's hard to bring in engineers and so forth into the industries in rural Pennsylvania when they realize they don't have health care when they want to start families and they want this way of life. So, Ariel, I'm ready. Let's get this going.
I sense you're talking to me, so.
We know we're going to have opposition from insurance and pharmaceuticals, but it's time we voice saying we have a solution. We need to start. So
Yes,
thank you.
And very concisely, HAP is very much laser focused this year on the financial stability, on workforce issues, on medical liability, and on regulatory reform. So you will hear much more from us on that, and to try to get folks to all really coalesce around some of these solutions. Yes.
Thank you, Representative Armanini. That was excellent on the concise point for both of you. I have one quick question myself, and then I'm going to turn it to Chairman Struzzi for one more question and some closing remarks. But a lot of conversation about reimbursement rates and federal monies and all those types of things. But our job as legislators, right, is to kind of look at the state like a business, right? We got to look at not just the money coming in, but the money going out. And if you're trying to fill a bucket with a hole in the bottom of it, the smaller you can make that hole, the more water you're going to have left in the bucket. So looking at some of the things that have come out from the American Hospital Association, looking at the estimated cost for providers, and this was several years ago, was about $39 billion nationally just for regulatory compliance. They estimate that any admitted patient costs the hospital $1,200 in regulatory and paperwork compliance before a single billable service is even provided. So as we're looking at, yes, being able to support our hospitals, make sure they're solvent, we also need to be looking at, and I know you already referenced this, the regulatory side of it, where if we're dumping money into a bucket, but all of that money is just going down the drain of regulatory waste, we have to have that bigger conversation about making the whole system sustainable, because at the end of the day, any money that comes from fees or subsidized programs or direct subsidies, that's all still just money coming from people who are already struggling, whether it's with the cost of living or existing insurance rates, those sorts of things. So I went to one of my local hospitals, and they told us that they had moved a television in a meeting room. It was a room like this. It was not even a patient room. It was not an operating room. It was a conference room, and they moved a television from this wall to this wall, and they weren't allowed to use the room for 2 months until DOH walked up and said, that's fine. and now they're allowed to use the room again. So my question, it could be for anybody. I know we talk about generally the need for permitting reform, but on the granular level, whether it's at IRMC, how many people are actually dedicated to just compliance, to just the paperwork, to just checking the boxes that whether it's federal or state, just the boxes that they make you check, some of which I understand the use for, some of which are definitely outdated and at this point are just pieces of paper going on a stack that nobody ever looks at again. So can you give us any sort of the specific, because as we go back to Harrisburg, as we draft legislation, something specific beyond just we need reg reform, we know. But what are the most outdated, most egregious, most absurd things like moving a TV to keep you from using a conference room that you guys deal with on a daily basis? And what is the cost specifically to you guys to comply with these sorts of things?
Yes, so I do think HAP has done a good job of trying to look at the state and prioritizing. So I've already got a list to get that out in terms of that. But I think we would probably say 20% would be a good number for us. I mean, there are lots of people that are really just meeting regulation, but I can get you a better number. I feel awkward in that I don't have it off the top of my head, but I'm happy to deliver that. And it's a real issue. Those numbers are staggering. I mean, if physicians were sitting here, they would talk about the number of people in their office that are never touching a patient, but just making all the hoops and everything. And it's a very big cost driver. So thank you for your sensitivity to that issue. Thank you.
And Steve, that's like 27%. So of a 1.0 FTE, the estimated time spent in direct patient care is like 0.27 FTE.
Well, thank you very much for that. I think it's eye-opening for a lot of people, just exactly how burdensome some of that stuff can be. So thank you guys for dealing with it. I'm going to turn it over to Chairman Struzzi for any final questions and some closing remarks.
Thank you, Chairman Rowe. Once again, I do appreciate everyone's time in being here today. I think we've heard some great testimony, some great solutions offered. I can't tell you how proud I am to represent Indiana Regional Medical Center and IUP and the people here in Indiana County in the 62nd Legislative District. I think to kind of maybe wrap this all up and tie it all together, we have an example in front of us in Dr. Meyer, a homegrown person, that chose to go to medical school to become a doctor. Would you care to share a little bit with us, what motivated you to get into the healthcare field? What made you come back to Indiana Regional Medical Center and do the residency program? Maybe just kind of bring us full circle and share your experience with us.
Mm-hmm. Absolutely. So I actually took a non-traditional pathway to medicine. I first was a medical assistant, actually at our orthopedics office here in Indiana as well for 4 years. While working, went back to school to finish my bachelor's degree at St. Francis University, and then took some prerequisites for medicine at IUP. So a lot of the discussions we had today, from being a medical assistant within the healthcare field, kind of addressing all pathways, not just the traditional pathway, but non-traditional pathways to medicine as well. And then went away from medical school, obviously, to St. George's University in Grenada, and then came back. So it was a battle between some Western PA residency programs, but obviously at the end of the day, I wanted to come back home to my roots and serve my community.
We appreciate that. Thank you. Well, once again, thanks everyone for being here. Thank you for your time. Thank you to my colleagues and staff who have come from long distances to be here today. I think this has been very beneficial to all of us, and hopefully we can identify and move forward with some real healthcare solutions for rural Pennsylvania. Thank you.
Thank you, Chairman Struzzi. I want to say again, thank you to all of our panelists for being here today. Thank you for the attendees, the member of the press that were able to be here, the representative from Senator McCormick's office there. You already moved over there. Good to see you, man. Thank you very much for being here. What we heard today, I think, really reinforces the importance of collaboration between entities on the state and local level. Addressing the challenges in rural healthcare, it's not a single policy, right? It's not a single institution that can solve the problem on its own. Because we know that physician shortages, regulatory burdens, they affect more than just access to care. They affect the affordability of care. They affect the outcomes of care and the long-term viability, especially of rural healthcare systems and the surrounding communities that rely on them. So when these communities lack providers, families and businesses they all pay the price. So addressing the work of addressing Pennsylvania's physician shortage is complex, but I think today's discussion was definitely made it clear that progress is possible. And in places like Indiana County, thanks to the hard work of all of you, the leadership of Chairman Struzzi, that work has already started. So thank you all for being here. Just a reminder, tomorrow at 10 a.m., we're heading out to Philadelphia to have our next hearing examine the new federal scholarship tax credit. Until then, this hearing is adjourned.